considerations when choosing treatment for myelofibrosis?
I mean, I would say in broad strokes, the primary considerations are the patient, what they want, the disease, what our options are, and the overall condition in terms of what are our possibilities for therapy and what is the risk benefit of some of these different therapies. So, in myelofibrosis, although there's been a huge amount of research over the past 10 years, really blossoming in a very impressive and I think exciting way, there really are only two therapies that are approved by the FDA for the treatment of myelofibrosis. And those both affect one class of agents. These are JAK2 inhibitors, and those can be ruxolitinib and fedratinib, are the two drugs that are approved. Now, we have a number of therapies that have been used off-label, meaning without FDA approval, so often and for so long that they're considered alternative standards of therapy. These can be growth factors, these can be biological agents in certain situations. And then clinical trials is really increasingly a common therapeutic option for patients. And then on the most aggressive side is hematopoietic stem cell transplant, an allogeneic transplant, getting blood-forming cells from another person and replacing the entire blood system through transplant.
So who is right for a stem cell transplant?
I would say first and foremost, an informed patient about the risks of transplant and a patient for whom a donor exists and a good quality donor. A transplant is not an option for some people if a donor can't be identified, obviously. And it's a patient for whom we can, the risk-benefit balance is tipped so that the potential toxicity, frankly, of transplant is warranted. Transplant, is our most aggressive therapy. It has a high, virtually every patient will have significant side effects from transplant. Some of them are short-lived, some of them can be chronic, and people die from the consequences of transplant. And so it's not something that is considered in patients who are necessarily, doing well or are frail. The risk of transplant versus the benefit may not be in favor of transplant at that time. My approach for transplant is to get advice from transplant physicians. I'm not a transplant physician, but I have colleagues who I refer to. And I refer in myelofibrosis fairly universally, fairly early, with the rationale being that this is information. It is not a plan. It is to speak to a transplant, to gather information. What kind of donor exists? If no donor exists, then transplant is not on the table. If we have a very good, high quality donor, then this is something that wouldn't make the decision in itself, but it's kind of something we can keep in our hip pocket in case we need it. And I think it's important for patients to understand and have a full and complete discussion with a transplant physician so they understand what that means. It is a significant commitment of time and morbidity, and it comes with risk. It is also our only curative therapy. And so it has it's a double-edged sword. And I think informed patients and understanding what the options are the sort of gateway to any consideration.